Good evening, good morning, good afternoon, everybody. Very warm welcome to all of you. This is the International Academy for Clinical Hematology, and I would like to welcome you to today's webinar dedicated to the latest advances in hemophilia, featuring a distinguished expert in the field, namely Professor Gili Kenet. So Professor Kenet is a professor of hematology, director of the National Haemohilia Center in Israel. She's head also of the Thrombosis Research Institute. And also, and this is really extremely important, she's coordinating the so-called PEDNet network or research network. This is the largest, actually, international pediatric database of patients with hemophilia from age 0 to 18. So we're extremely grateful to Professor Kenet, who is globally recognized leader in bleeding disorders with a wealth of experience in both clinical and translational research setting. So over the next 30 minutes or so, she will explore with you the emerging therapies, the novel treatment paradigms, and the impact of some of the already approved and innovative therapies and factor replacement strategies. And as you may guess, with the rapid scientific progress reshaping the whole hemophilia management, I'm sure this session will allow you to get a glimpse of the latest updates and also, most importantly, the practical insights that will benefit both clinicians, researchers, but also patient and family members. As usual, at the ICH, we do encourage you to engage actively. Please share your questions and participate into the discussion. So without any further ado, please join me in welcoming Professor Gili Kenet. Gili, the floor is yours.
Thank you very much, Muhammad, for that warm introduction. And now we can discuss the future perspectives of hemophilia care. These are my disclosures. As you all know, hemophilia is a disease of poor thrombin generation, and hemophilia patients bleed because their thrombin generation is much lower than the regular peak or endogenous thrombin potential of a non-hemophilia patient, as you can see in this slide. The hallmark of hemophilia bleeding phenotype is bleeding into muscles and joint. Joint bleeding causes synovitis and eventually cartilage and bone changes that lead to deterioration of joint status and to surgeries at young age. Here you can see a picture showing you how hemarthrosis looks and how joint damage looks in a plain X-ray. You can see that from a young age, infants with hemophilia may suffer skin hematomas, joint bleeds, and even deterioration of intracerebral hemorrhages if they are not treated properly following trauma. But those who are the severest hemophilia patients can also bleed spontaneously. The detrimental effects of intracerebral hemorrhages that may occur in up to 4% of infants with hemophilia around delivery can somewhat be prevented if we start prophylaxis in an early age to avoid spontaneous bleeding in hemophilia patients. Of course, there are issues like venous access, the need for central venous access devices in small children, and of course, the present risks associated with blood products and blood clots of those central devices, etc., 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 that limit the initiation of prophylaxis to slightly older age. And this is why, actually, we need novel drugs, because infants may have problematic venous access, also because about 30% of patients with severe hemophilia A and 10% of patients with severe hemophilia B, once exposed to replacement therapy, to coagulation products, would eventually develop inhibitors to those coagulation products that make their care much difficulter and require use of bypassing agents that have a lower half-life and are somewhat more thrombogenic. So let's have a look at the landscape evolution and shifting paradigm of hemophilia care. In the early 1950s and 60s, patients were treated by blood product, and the aim was supportive care to avoid morbidity, to avoid mortality, to avoid invalids among the hemophilia patients. Then from their blood products, replacement products were produced, either short half-lives or long half-life, plasma-derived, recombinant, and then our aim shifted towards zero infections in the era of HIV and hepatitis C. From replacement products, starting at the last decades, non-replacement products evolved, and we will talk about this. Now the target was not only zero infections, because these are not any recombinant products. The target is now zero bleeds, and of course, zero factor inhibitors, because this is not replacement therapy. Eventually, from 2020 and beyond, we came to the era of functional care and of potential cure by gene therapy. Why do we need all these products? First of all, we do have now good replacement therapy by standard half-life or extended half-life products that are infused intravenously, usually independent by the patient at their home. It's completely ambulatory care, but patients who are receiving proper prophylaxis still experience some bleeding episodes, even if they are completely adherent to the treatment regimen. So let's have a look at this slightly complicated slide and make some order into the new era of treatment. You can see the treatment evolution from up down. This is the coagulation cascade that we are all familiar with. And naturally, treatment started with either factor replacement, shortened half-life or extended half-life. And for the inhibitor patients on the right side, you can see the bypassing agents that were used because coagulation factors do not work anymore in the presence of inhibitors, either activated prothrombin complex concentrates or recombinant 7A. In the last year, the evolution goes to two directions. Non-replacement therapy for hemophilia A could be molecules that are factor VIII mimicking, bispecific monoclonal antibodies that bind factor 9 and 10, and therefore they replace the role of factor VIII, and therefore patients with or without inhibitors can be treated by them if they are hemophilia A patients. For non-hemophilia A and for hemophilia A as well, there are the rebalancing agents targeting the natural coagulation inhibitor proteins, tissue factor pathway inhibitor, antithrombin knockdown, APC inhibitor, serpin PS inhibitor. Most of these are still on clinical trial phase. And of course, last but not least, we should mention the gene therapies that are currently approved. In this lecture, I'm mainly going to talk about the products that are already registered and in use in Europe, Israel, and the United States. The first one would be emicizumab, a bispecific antibody targeting factor 9 and 10. The HEAVEN studies published in the last years have shown that it is safe and efficacious for treatment of patients with hemophilia A with and without inhibitors, either adults or adolescents, or pediatric patients above the age of 2 years. Recently, there was a Blood publication about a pediatric study addressing previously untreated patients or minimally treated patients younger than 1 year of age. In this study, 55 patients received emicizumab prophylaxis from age 0 until 1 year. These patients will continue to be followed for the next 7 years to look at the long-term outcome, but the pilot results were quite promising with good efficacy and good safety. 2 out of these cohorts developed factor VIII inhibitors following occasional exposure to factor VIII for treatment of breakthrough bleeds. If we look into real-world data from the PEDNET registry that encompasses now 3,000 patients over Europe, Canada, and Israel, you can see that the median age for prophylaxis, starting usually with emicizumab because of its easy administration, subcutaneous injections every week or every second weeks, is now around 9 months. The PEDNET cohort is quite similar to the Heaven 7 cohort. It now contains 56 children. Out of these, 40% have never been treated before, and about 60% had some exposure to factor VIII, but less than 5 exposure days. And in our cohort also, 2 children developed factor VIII inhibitors, and we continue to follow them. What about the aging population? The life expectancy in hemophilia is similar to the rest of the population. So while children cope with when to start prophylaxis and how to deal with prophylaxis when the venous access is an issue, in the aging population, we now see those who had hepatitis C in the past but recover. They still may suffer cirrhosis, and they still may suffer portal hypertension, variceal bleeding that are challenging in hemophilia patients, or develop the tumors such as hepatocellular carcinoma. It is well known that there is a connection between cancer and thrombosis. However, hemophilia patients are not protected against cancer. Cancers are abundant in patients with HIV, HCV, and in others. So in the elderly population, we should face the challenges of regular elderly population, plus the challenges of post-infection in this population, plus the challenges of venous access. A special interest adult cohort that was followed in our center was a cohort of adults above the age of 50 years, all of them with either hepatitis C or HIV, with cardiac risk factors, some of them following cardiac catheterizations or even coronary artery bypass grafts. They had hypertension, diabetes, they were smoking. They were followed for more than a year under emicizumab prophylaxis. And interestingly, their annual bleeding risk was low, with reduction of painkiller consumption. The mucocutaneous bleeds correlated with use of antiplatelet agents that they used for their cardiovascular conditions. But apparently, no thrombosis occurred in this cohort under treatment of emicizumab, and no thrombotic microangiopathy that was documented in the first stages of the Heaven studies among adults who were treated concomitantly with high repeated doses of activated prothrombin complex concentrates. So these data are quite promising. Emicizumab could be used among a variable age range, starting from age 0, even right after delivery if the parents are very anxious and afraid of intracerebral hemorrhage, to the very old people without any specific safety concerns. Apart from emicizumab that is well used and registered in Europe, US, Canada, Israel, and worldwide, there are other bispecific antibodies that are almost similar with different binding points. The 8-MIM by Novo Nordisk, the NXT007 by Roche. All of these are 8-mimetic bispecific antibodies, and we ask ourselves, is this the ultimate solution for hemophilia A prophylaxis? Well, While studies and real-world data of emicizumab only are promising, there have been reports of thrombosis and TMA in the first studies of emicizumab. We still do not have enough surgical data. We still do not have enough data regarding the previously untreated, the smaller children. There is a laboratory impact of emicizumab upon assays. The PTT becomes shorter because of the binding of factor 10 and factor 9, and apparently all laboratory assays should be performed with special reagents, with bovine chromogenic reagents using special techniques. So we are not sure whether we should change the monitoring of patients, whether we should change the way our lab works because of the frequency of emicizumab use. And of course, there is the question that is very important to us, how to achieve or how to maintain factor VIII tolerance if those children and adults are not at all exposed to factor VIII. If they had inhibitors and were tolerated in the past, would lack of factor VIII use expose them to reoccurrence of inhibitor due to anamnestic response? Should we use factor VIII concomitantly, but then we lose the advantage of subcutaneous administration versus the IV use? These questions remain open, and I assume we will have better answers for them in the next coming years. What about factor VIII? Apart from the short half-life and extended half-life products that currently exist in the market, there is a new factor that was recently approved in Europe and in the US. And this factor, the I2-VOCT or the EFA alpha, provides high sustained factor VIII levels throughout the dosing interval. So it is a super factor VIII, an extra long extended half-life factor. If you give like 40 units per kilo to a hemophilia patient, a week afterwards, you end up with a level of 10 to 15%. And this impact is sustained from week 1 of the study to about 1 year at a steady state of 47 hours. So the PK profile does not change. The level of the factor is sustained at levels similar to mild hemophilia A. These patients will bleed only if they experience severe trauma or have to undergo surgery. And the levels that are sustained are somewhat even higher than the level maintained of factor VIII equivalent under emicizumab prophylaxis. The trials were very promising, and they showed reduction of bleeding, reduction of the annual bleeding rate at 6 months intervals in all patient groups. Patients that had target joints that bleed more than 3 or 5 times for half a year or a year lost their target joints after 12 months of using of that extra extended factor VIII half-life. The joint score markedly improved, and the ultrasound that is used to monitor joint status more sensitively than joint score also improved. So this is a very, very promising factor VIII, and it is now a matter of patient caregiver shared decision process to decide whether to use this once weekly IV infusion of factor that will end up after a week in a status of mild hemophilia rather than severe hemophilia A, or to go for the 8 mimetics injected subcutaneously every week, every second week, or every month. Let's switch gears and talk a little about the rebalancing agents. These are drugs that target the natural anticoagulants. For example, we all know that patients with antithrombin deficiency have a very high prothrombotic tendency. There have been few reports of patients with antithrombin deficiency and hemophilia that hardly bled at all. Increased thrombin generation rebalances hemostasis even in the absence, complete absence of factor VIII or factor IX, and even in the presence of factor VIII or IX inhibitors. So there is a small interference RNA called fitusiran that is close to registration by FDA these days. This antibody targets antithrombin in the liver. It reduces antithrombin production and therefore it restores thrombin generation. However, some of the patients may suffer transaminitis with increased liver function test, and some of them were reported with thrombosis that required mitigation of the protocol of the study and lowering of the doses of the drug. Here you can see an experiment that was performed in our lab in Tel HaShomer. This was prior to the fitusiran clinical studies. We took plasma of hemophilia patients with inhibitors and of healthy volunteers, and we spiked it with increasing concentrations of antithrombin antibodies, similar to fitusiran. You can clearly see that this increased the thrombin generation, and as reported by the company now, antithrombin concentrations of 15 to 35% are safe and probably would not induce thrombotic complications. There is another category of rebalancing agents that are currently already registered, and these are the IgGs against anti-tissue factor pathway inhibitor. The studies are currently ongoing, especially in pediatric population. Some studies of some companies were stopped because of thrombosis, mainly arterial thrombosis. Concizumab, which is an IgG targeting anti-TFPI produced by Novo Nordisk company, has recently been registered in Europe for use in hemophilia A and B patients with inhibitors above the age of 12 years. Marstacimab was registered by Pfizer company for use in hemophilia A and B patients without inhibitors, and both companies have studies ongoing for patients with and without inhibitors. We do not have any early pediatric data or patiently untreated data. We do not have enough surgical data, of course, with these drugs, and no one can tell where the future is going. So if we are looking more carefully into the rebalancing agents, trials for hemophilia A and B patients with and without inhibitors are still ongoing in that category. Pediatric data are very few. There are a few cases of thrombosis that have been reported with fitusiran or with various anti-TFPI. There is a need for reversal agents. For fitusiran, you can give antithrombin. I don't know if this is really recommended because that will restore the status of hemophilia with or without inhibitors. But for anti-TFPI, there is no reversal agents if needed. Information is lacking regarding the very young patients or surgeries. Monitoring of hemostasis is difficult. Maybe we should use the global assays such as the TEG, ROTEM, or thrombin generation that are not readily available worldwide. And we do not know how to achieve and maintain factor VIII tolerance because factor VIII or factor IX are not required anymore in the presence of these agents. So in the world of mimetics and non-replacement therapies that are rebalancing agents, unfortunately, not all patients achieve bleed-free status. Additional hemostatic agents are required to manage breakthrough bleeds, to manage surgery. Non-factor replacement is not approved for the management of acute bleeds. It only provides a good option for prophylaxis, unlike factor replacement therapy. There is a small number of cases reported with neutralizing antibodies, which can result in loss of treatment efficacy. And there is lack of knowledge regarding the long-term impact of non-factor replacement on joint and bone health because some people still think that factor VIII is important for joint and bone health apart from its role in hemostasis. We cannot finish this talk without talking about gene therapy. Hemophilia is an ideal candidate for gene therapy because it's a single gene disorder, because the product of gene therapy, the restoration of factor 8 or 9, has a wide therapeutic window. Even a low level of expression would improve dramatically the outcome and reduce the bleeding, and higher level are certainly welcome. And efficacy is easy to assess either clinically by reduction of bleeding and factor consumption, or laboratory by assessing the factor levels. Currently, there are numerous studies of gene therapy that are planned or still recruiting patients in hemophilia A or hemophilia B. A variety of viral vectors are under investigation. Most studies are currently using AAV vectors, but other vectors are also being evaluated. Of note, AAV is a non-integrating product, so we are not afraid of cancer, unlike the lentivirus that seems more efficacious but may be carcinogenic. Transgenes that are used include either the B-domain deleted factor 8, that is a very long gene, therefore the non-functional domain is deleted prior to gene therapy, or factor 9 high activity variants. And there are also some gene editing studies that are in early phase trials using CRISPR and other modes of administration. With regard to hemophilia B, there are two products that are currently registered in the US, EU, and Canada, one product of CSL, one product of Pfizer. Both showed good efficacy and safety during the clinical trials. The price is very, very high, so very few patients actually use them following the trials. With regard to hemophilia A, there is a product by BioMarin. The studies started 6 years ago, included 134 individuals worldwide, including 5 in my country. And as you can see, the use of B-domain deleted factor 8 in AAV resulted in high increase of factor 8 level throughout the first year. Levels later declined gradually and stabilized throughout the third or fourth year, with good efficacy in over 80% of patients who have now fully recovered from disease and do not require use of factor 8 anymore. This is the elephant in the room. Not only gene therapy, but all the other non-replacement therapies are quite expensive. So whether or not to use them also depends on health economic considerations. If we look once more into the scheme of paradigm of care of hemophilia nowadays and treatment individualization and the different therapeutic choices that hemophilia patients have today, first of all, they have very good replacement therapy, either by recombinant standard half-life or extended half-life therapies. And these factors are good both for bleeding prevention, but also for bleeding treatment. It is possible to measure the effect with good lab monitoring. It is possible to modulate the effect, to assess peaks and troughs, but they require IV use. The non-replacement therapies, either the 8 mimetics or the rebalancing agents, are used for bleeding prevention only. They are conveniently applied by a subcutaneous route. They are effective also in inhibitor patients, but there are still unknown points, and thrombotic risk, lab monitoring, and more follow-up is needed to define safety. What about gene therapy? Its aim is to restore the endogenous production of coagulation factors and to fully cure the patients following a single IV injection. But of course, there is unpredictable efficacy, and gene therapy currently is not available for children. It's not available for patients with inhibitor. It's not available for patients with liver disease, and the long-term safety and efficacy are still not available to us. With that, I would like to close my talk. I think we will have more exciting data in the next few years, and I would like to thank all my colleagues in the Israeli National Hemophilia Center, that's the upper photo, and all my colleagues in the PEDNet Research Foundation. Keep calm, as the science says, because hemophilia became an exciting disease with exciting option, and there is much more to come in the next future. Thank you very much.
Thank you very much, Professor Kenet, for really an outstanding webinar, very comprehensive. And I love the optimistic note showing all of these exciting developments. So we have some time for Q&A, if you allow me, and I'll try to structure the different questions we have received. One question is about whether there is a specific geographic distribution for hemophilia across the globe, or is it a very broad disease?
Of course, like any rare disease, there is a matter of consanguinity that may increase the hemophilia frequency at a certain area. However, hemophilia frequency is quite fixed. It occurs in 1 to 5,000 male births for hemophilia A, 1 to 30,000 for hemophilia B, and it's similar worldwide regardless of ethnic origin.
Excellent. Thank you very much. We have a question about the non-replacement treatments where apparently, I mean, I saw it on the slide, you highlighted it's mainly for prevention. And the question is whether in some situation this could be used in case of bleeding.
No, it gives you a background activity, a background hemostasis activity, because it's sort of, if I always describe to the parents the coagulation cascade like a train running forward. And if the train, one of the wagons is missing air, it will not run very fast. Like you have to replace the air in the wagon, you have to give factor 8 or factor 9 for the train to ride better. But your other option is just to lower the brakes. So if you lower the brakes, the train runs fast. This is the non-replacement therapy, but it does not achieve 100% hemostasis. There is a new drug coming to the market. This would be the NXT 007. 00 stands for zero bleeds and zero factor replacement. And Roche claimed that for patients who are using these drugs, no need for additional factor 8 would be required in case of breakthrough bleeds, but time will tell.
Excellent. Thank you very much. So we have also a few questions about gene therapies. And of course, there is a lot of excitement about this. And I think you discussed some of these options. And as you have nicely highlighted, follow-up is still relatively short. And of course, pharmacoeconomics is a matter of concern, especially in those countries with low and middle income. But here, I don't think you have mentioned this, but we have a question that there was a paper a couple of weeks ago in the New England Journal of Medicine from India, where one would assume the pricing would be relatively reasonable, about gene therapy in hemophilia. What are your thoughts? Because I think maybe this trial is different from the approved products, approved gene therapies in Western countries.
Okay. Most gene therapy trials in hemophilia and the products that are already registered today use AAV as a vector because it's non-cancerogenic, because it's non-infectious, because it's quite easy to use, and there is currently experience of over 10 years in gene therapy in hemophilia B with AAV-related techniques, and in hemophilia A, the current experience is of 6, almost 7 years using the AAV and the factor 8B deleted product. First of all, we should know that hemophilia is not a lethal disease. I just mentioned that the life expectancy of hemophilia patients is normal. So when we think of hemophilia therapy today, we should consider the burden of disease versus the burden of treatment. The burden of treatment of gene therapy is not simple. I have treated patients with gene therapy in my center. They should get the infusion and they can respond with an anaphylactic reaction. Then afterwards, they should be monitored every week or every second week or every month to look at the liver function, to look at the increase of factor levels. If the increase is not sufficient because of transaminitis, they get steroids. If steroids are not sufficient, then they get second line therapy that could be far more aggressive. It's not like an easy trip, not an easy burden to take. Now, if you go to lentivirus, the burden is even higher. Lentivirus may cause cancer. If you go to that special Indian paper, only 5 patients in India, and they had to undergo full myeloablation in order to receive the gene product with CD34 cells. So why should I put a hemophilia patient to such misery? Myeloablation, lentiviral gene therapy of whose safety I am not fully uh, aware and fully concerned, and I do not know how to evaluate it for the long term, just to bring him to the level of mild hemophilia A patient, I could use a emicizumab. I could use another kind of very conveniently applied non-replacement therapy and wait a few years until we have more data, until gene therapy matures, until it becomes cheaper, until it becomes more accessible and even more safe before I reintroduce it. With specific regard to that New England manuscript, let me say, I think it is outrageous, really.
Okay, thank you very much for sharing your opinion, and we'll stay with the therapies of hemophilia. And we have a question here whether there are specific epigenetic factors that can influence the response to the different available treatments.
This is a very interesting question. We are not quite sure yet. We know that the genetics certainly affects the severity of hemophilia and the tendency for inhibitor formation, even though there are danger signals that are also involved, such as intensive use of products throughout a young age or extensive periods of infection, inflammation, bleeding, and other environmental factors. There are confounders such as presence of thrombophilia that may modify the risk of bleeding among hemophilia patients. We are now checking within the PEDNET. This is a very interesting thing because within the PEDNET studies, we have, as I told you, 3,000 kids, and 86 of them are fully genetically mapped. So we are now addressing not only the risk of inhibitors, but the impact of, for example, immune tolerance to tolerate the inhibitors related to the epigenetic factors, whether or not these could predict the success or the non-success of immune tolerance. And I assume that we will find some positive results because we know that the appearance of high responding of the dangerous inhibitors is associated with the genetic background. And we know that this is also associated with the success or the lack of success of achieving immune tolerance. So with regard to genetic factors that may impact the fate of non-replacement therapy, we will have to wait for several years and for some more data. But it's a very interesting question. Thank you for raising it up.
Thank you. And again, congratulations for this incredible cohort you are coordinating. I believe at some point this will help to really modify the natural history of the disease. We have another question here where I must confess I personally never thought about it, although I'm roughly 99.9% ignorant in hemophilia. Why is hemophilia still underdiagnosed and under treatment in women and carriers? And another question we had, whether should we redefine hemophilia classification to include female patient with low clotting factor levels?
Okay, I will start with the second one. The answer is yes. When I started treating hemophilia almost 30 years ago, I was told if a patient have factor level that increases 20%, he is not hemophiliac. He can undergo surgical procedures with use of tranexamic acid only. He rarely bleeds. Do not worry about him. The WFH changed these definitions in the last decade. Now the definition of hemophilia is below 40% and not below 20%. Some of the women carriers do have levels that are below 40%. So now they are defined as mild hemophilia A patients. But like other rare bleeding disorders, women with bleeding disorders are underdiagnosed. When they complained of prolonged menarche or abnormal uterine bleeds, every time people tell them, okay, you're a woman, that is expected. And many physicians do not bother to go and check the factor levels because they assume that if a woman is a carrier, the healthy gene would take over the phenotype and the woman would not have lower than normal factor VIII levels. Actually, there can be women with severe hemophilia due to extreme lionization. These are easily recognized and at early age. It is the problem of those with moderate or with milder hemophilia that are less recognized because of less awareness. And this is not specific to hemophilia. It is a common phenomenon for all rare bleeding disorders worldwide. And indeed, we should increase awareness because the definitions have changed. And these women require care in order to avoid postpartum hemorrhage and other severe complications.
Thank you very much. That's very clear and straightforward. Let's move to another question now. We're moving from women to the older population. And again, I think this is a very to the point question, in my opinion. How do we balance the risk of thrombosis with the need for bleeding control in those older hemophilia patients who have already risk factors for thrombosis?
Well, this is not an easy task, and it should be dealt with by coagulation experts because sometimes we need to correct the hemophilia by full treatment with factor concentrate or by partial treatment with rebalancing agents before introducing the antiplatelet agent or the anticoagulants. There is a constant debate among hemophilia treaters. For example, you know that it is common practice to give anticoagulants following joint replacement surgeries. Hemophilia patients undergo joint replacement surgeries in young age. Should we anticoagulate them? If you're coming from my country, you would say, no, we will just reduce the level of correction of the factor concentrate and not increase it to 100%. Let's say keep a 50% correction, and then we will avoid thrombosis. If you come from Belgium or from Sweden, they will say increase the factor level to 90, 100%, and anticoagulate, of course, modifying the dose. So this balance is a matter of geography, a matter of experience, and a matter of suits that should be tailored for the individual patients. Many patients with hemophilia nowadays have atrial fibrillation for which they are treated. Many patients who had cardiac cath or CABG surgeries are being treated by antiplatelet or even by anticoagulants. But all these that are being treated should be, to some extent, corrected with regard to their coagulopathy, because otherwise this will lead to bleeding complications.
Okay, thank you very much. For the sake of time, if you allow me, I'll take one last question because I always think that now these days you cannot do anything without someone asking you about artificial intelligence. So can artificial intelligence improve hemophilia care and predict bleeding risk more accurately?
It depends. because in order to use AI, you should have large databases that are very accurate and with many details that are sometimes missing. If all our patients would walk around carrying an app in their phone or carrying tablets and putting in constantly all the data of bleeding and the circumstances and the locations and the degree of correction by treatment and how far they were from their last infusion or the last injection, then AI would be very, very helpful. But since any AI can only rely on the real world data, it could help to some extent. It could not fully predict, unfortunately, not under the current circumstances.
Wonderful. Thank you so much. And we are going to conclude this fantastic webinar on the latest advances in hemophilia. I'd like to extend my sincere gratitude to you, Professor Kenet, for sharing your expertise and for guiding us through these groundbreaking developments. If I summarize today's discussion, I think you walked us through the remarkable progress from novel gene therapies, the extended half-life factor products, transformative impact of non-factor replacement therapies, and I learned a lesson that in hemophilia, it's not a matter of quantity of life or years, it's a quality of life. And obviously, protection against bleeding, reducing the treatment burden, and more personalized therapies are really required. So on behalf of the ICH, I'd like to thank all participants for joining us today. I believe your engagement and dedication to the field are vital in driving continued progress. So here at the ICH, we look forward to welcoming you to our future ICH events. And there's one scheduled for tomorrow, same time. So thank you very much. And wherever you are, please stay safe and keep well. Thank you very much.
Thank you very, very much. It was my pleasure. Looking forward to meet you again soon.
Thank you.
Bye-bye.